Good afternoon.
Welcome to Climate Change and Health in Small Island Developing States focused on the Caribbean. If you require translation into Spanish or French, please use the link posted in the chat and choose your desired language at the bottom of the Zoom screen. You should continue to keep the browser open as well to utilize the chat and Q&A features. Please be sure to scroll down and mute the video. Please use the Q&A feature to submit any questions to the panelists. This session is being recorded. Thank you.
Thank you, and good afternoon, colleagues. My name is Hugh Seeley. I'm a lecturer in the Center for Resource Management and Environmental Studies at the Cave campus of the University of the West Indies. I'm also a special envoy of the Government of Barbados on climate change, and I have a particular interest in the nexus between climate change and health. I have the honor of being your moderator for this session, which is going to be on developing resilient health systems. We have a great panel with us today. We have 4 panelists. We have Dr. Jonathan Drury. He's a regional climate change and health advisor with the Pan American Health Organization based in Barbados. In this position, he provides technical cooperation in the areas of climate change and health and the environmental determinants of health. He is the project manager for the implementation of the EU CARIFORUM, Strengthening Climate Resilient Health Systems in the Caribbean project. Prior to this position, he was a director of the US Peace Corps in Colombia. He has worked in public health leadership, programming, and management for more than 25 years in the Americas. He has a master's in public health and a doctorate in public health. He has been a registered environmental health specialist through the National Environmental Health Association since 2004. Welcome, Jonathan. We also have Major Clemens Buter. He's a Dutch national. He's a graduate of the Royal Netherlands Naval College with a degree in International Security Studies. He has served as a Marine commander for the Royal Netherlands Navy for over 20 years with ample field operations and humanitarian and disaster assistance experience. For the past 5 years, Clemens has joined the Health Emergency Department of the Pan American Health Organization as the lead planning and operations advisor for the implementation of the Smart Hospitals Initiative in the Caribbean sub-region. As a member of the PAHO's Regional Health Response Team to emergencies, Major Buter has contributed to disaster response efforts to several major health emergencies that affected the Caribbean sub-region over the past few years, including the responses to Hurricanes Irma and Maria in 2017 and Hurricane Dorian in 2019, facilitating civil military coordination support, as well as logistics and operations for disaster response assistance. Since the onset of the explosive volcano eruption in St. Vincent and the Grenadines in early April this year, he's been coordinating PAHO's response efforts as incident manager for this emergency. Welcome, Major Buter. We also have Dr. Judith Harvey. She holds a PhD in engineering from Cambridge University and is a chartered engineer with the Institute of Civil Engineers in the UK. She is registered as a civil and environmental engineer in St. Lucia and is presently a technical consultant on the Smart Healthcare Facilities in the Caribbean project. This project is funded by the UK's Foreign, Commonwealth and Development Office and implemented by the Pan American Health Organization in partnership with the local Ministry of Health. And finally, we have Dr. Ravati Falke. She's the head of the Climate Change and Health Group at the UK Health Security Agency, formerly Public Health England, and an associate professor for global health at the Heidelberg University in Germany. She brings over 15 years of experience in delivering interdisciplinary, multi-partner research capacity strengthening projects in Europe, South, Central Asia, and West Africa. Her main interests lie at the intersection of climate impacts and the challenge of operationalizing resilience within health systems. She leads the 4th National Climate Health Risk Assessment and is the health focal point for the National Adaptation Program. Dr. Falke is a contributing author to the IPCC 6th Assessment Report, the lead chapter author for the UNFCCC Adaptation Gap Report, and leads the UK HSA's input to the COP26 health program. Welcome to you, Dr. Falke, as well. So, colleagues, we have a very limited time. We have until 2:50. What I'm going to ask the panelists to do is to present for about 8 minutes maximum each, and I will be dealing with the time, and that should leave us a few minutes at the end for questions and answers. So, Jonathan, Dr. Drury, you have the floor.
Thank you, Dr. Seeley. It's really a privilege to be with you all today and have a little bit of time to speak about this exciting novel new project through the EU CARIFORUM, and it's strengthening climate resilient health systems in the Caribbean. This project really relates well to everything we've been talking about this week and over the coming days. So I think it's very much pertinent to our discussions. This first slide, really, when we think about what are the challenges for the health sector, a lot of things come up. Most of these we've discussed on day one. Dr. Taylor went through many of these, so I won't provide a lot of detail, but we know the climatic impacts. We know that there's a need for more research, in particular translational research. We know that there are even more demands on the vulnerable populations, and there'll be new vulnerable populations in the coming years. And so all these issues are important to consider: the vision of the health sector, the sensitivity of some of the sectors, tourism and agriculture, and also, as Dr. Taylor mentioned, really needing a mitigation champion within health and the importance of promoting health in that agenda. Next, please. So the Pan American Health Organization has been working on climate change and health for some years. These are some of the areas that we cover here in the Caribbean and elsewhere in the Americas. Governance, planning, infrastructure such as smart hospitals, early warning systems, immediate benefits, co-benefits of health, and how do we promote those, training, capacity building, and financing. This next slide gets it. This next slide gets at some of the partners and some of the outputs of this project. As you can see at the top of the screen, this project has really brought in an array of partners from across the Caribbean. We have CARICOM, the 5 Cs, CARFA, CIMH, UE, St. George's University, UNICEF, and many others. And the key outputs are really listed here just to give you an overview. One of those is this interdisciplinary approach, not only at the sub-regional or regional Caribbean level, but also at the country level, moving forward with this much desired area of health national adaptation plans to really advance those at the national level. Communication, awareness, how do we really move forward the health co-benefits? How do we address the environmental determinants of health that are water, sanitation, air, and then modeling systems to link up climate and health and other sectors, and then the future workforce demands. Next, please. Back one slide, please. Thanks. Yes, so these are the 16 CARIFORUM countries that this project will directly benefit. So you can see it's a wide array of countries from the Caribbean. Next, please. So the first couple of outputs I'd like to talk about are really the immediate benefits and health national adaptation plans. So this area is really led by PAHO, but also by the 5 Cs. And the beauty of this project is all of the outputs really require an all-agency approach. So there are some leads on each of these, but all agencies have really been involved. So the gap we're looking at here, as has been mentioned in previous sessions, the need for more to be done with mitigation, either because there's not the awareness, there's not the capacity, or there's not the funding within the health sector. Also, the ability to prioritize health outcomes at the national level through the HNAPs, and then the increase in health and climate financing. So these are some of the accomplishments. This is a 5-year project. We've just finished year 1. Some of the accomplishments here are training countries in some of the more prominent PAHO WHO tools, determining countries that can really move those forward as pilots, training of countries in how to develop a comprehensive health national adaptation plan and what really is the value of that. And then selection of countries to move that forward, which will include interministerial committees, a lot of the other issues there too. So I think that's an important one. The second one is really developing climate-informed surveillance and risk monitoring systems. So CARFA and CIMH are leading this. The gap there, as Dr. Stewart Ibarra, Dr. Cashman have talked about, are really the linkages between climate, health, and data sources to address issues of the air quality, Sahara dust, dengue, respiratory illnesses, et cetera. So that one is also tied in with climate resilient water, sanitation, and food safety plans. Next, please. Leadership. So how do we establish really a cadre of future leaders in the Caribbean? And that's really what the gap here is. This area is being led by UE and also CARICOM. So we're getting at professionals from different sectors and also at youth in the Caribbean. We saw some of the passion on day one with Ashley and Priyanka, who also have supported this project. So some of our accomplishments here have been a UE leadership curriculum and fellowship program that's being developed with the first cohort of fellows underway. Dr. Chris Orr will talk more about that this afternoon. CARICOM youth ambassadors have been selected to work on climate and health projects and as advocates in their countries. Next, please. We know there's a gap in the Caribbean to address these target populations about the importance of climate health. So how do we go about doing that? If we've held some events, project inception, we've also developed project logos, slogans, and videos. Launched a public perception survey. Next slide, please. So what are the main takeaways here? Well, the main project contributions really is that this places a lot of importance on climate change and health projects that engage across agencies, sectors, and countries. So as James Hospitales said, we need to look for ways to break down silos or join them up. And I think this project really does that. Also, the opportunity to generate systems and data to support the climate and health agenda. An opportunity to scale up some of the areas that we learn in some of these projects across the Caribbean, and then provide countries with more evidence and priorities to then elevate health and facilitate inclusion. So these are some contacts from PAHO that have been involved in this project, and if you'd like to learn more, please visit our website below. Thank you for your time.
Thank you very much, Dr. Drury. And you stuck to time as well. I think you gave us an extra 60 seconds, but thank you very much for that introductory presentation. I'll move straight to Major Buter for his presentation. Clemens, you have the floor.
Good afternoon, everybody. Thank you, Dr. Seeley, for the kind introduction and the great opportunity to present to everybody the Smart Healthcare Facility Project in the Caribbean in the next 8 minutes, so I will stick to the timeline as well. As we all know, the Caribbean is hit by natural disasters every year. And in the event of an emergency, health facilities to treat the sick and injured are vital. Over 2/3 of hospitals in areas of higher risk of disaster and health services are frequently disrupted following storm, hurricane, earthquakes, or heat events. And of course, we all remember the recent eruption of the La Soufrière volcano in St. Vincent. The current pandemic and climate change will further increase this level of risk in the Caribbean. Let me go back one. More than 67% of hospitals in Latin America and the Caribbean are in areas at high risk for natural disasters and climate change. At the same time, hospitals represent almost 70% of the ministry's health national budget. In the Americas, 61% of the impact on health facilities is caused by earthquakes, 17% by hurricanes, 14% by floods, and 8% by other health emergencies. This leaves millions of people without proper health care and resulted in billions of dollars in direct cost. In phase 1 of the Smart Hospital project in 2013, a demonstration retrofit project was done. The first one was at the Georgetown Hospital in St. Vincent, which was an older facility, and the second one was at the Poxon Hospital in St. Kitts, which was newer, but both of these projects proved to be successful. The retrofitting works included replacing the windows to meet higher design wind speeds for the region, strengthening of the roof to accommodate solar panels, and also by that time already ashfall in St. Vincent, who would have known. Improving the natural lighting and ventilation, and improving the fire safety and emergency egress of the facilities. 10 months after the completion of this Georgetown Smart Hospital, the energy data was reviewed, and it was estimated that a 58% reduction was achieved in electrical consumption. Similar checks were done at the Poxon Hospital in St. Kitts, and that facility showed a 50% reduction. Phase 2 of the smart healthcare facilities in the Caribbean project started in June 2015, so based on the success of phase 1. And as being mentioned already, it's currently implemented by the Pan-American Health Organization in very close collaboration with the Ministry of Health in the 7 project countries. And these countries are mentioned in the slide. The project is funded by formerly known as DFID, but currently the UK Foreign Commonwealth and Development Office in the amount of £48.2 million. And after an extension, it will end by the 31st of December in 2022. So what are the results? And the slide shows a few great pictures. This is the Chateau Belair Smart Hospital in St. Vincent. And it shows you how the situation was before, then a 3D model was created, and then of course the result. And of course the facility was impacted by ashfall, but after a very good cleaning, the facility is operational again. And most importantly, all medical equipment inside was not damaged. So what do we achieve? We achieve enhanced safety standards, reduced downtime and damage to healthcare facilities from natural hazard, lower operating expenditures due to the savings in water and electricity, and we build national and regional capacity to apply the smart standards. I will give you a few examples later. So what is smart? A smart facility is both safe from natural hazards and is also green. There are several win-win ways to accomplish this, which in the process can be cost effective, cause a reduction in greenhouse gas emissions, achieve climate change adaptation measures, risk reduction and development benefits. The image shown in the presentation defines what is meant by smart. It illustrates that improvements in safety or an A score on the hospital safety index results in a safe facility. A score of more than 70% on the green checklist equals a green facility. The graphic presents safe and green factors to consider, and when these are combined, help to create a sustainable smart facility. And of course, maintenance, especially preventive maintenance, add to the success as well. So now we're not only saying safe plus green is smart, but we're saying safe plus green plus maintained is especially smart. Other measures, such as the use of eco-friendly flooring, paints, furniture, and furnishes, will further contribute to increased sustainability and risk reduction. Health facilities can also improve their smartness by greening their operations. This includes using less paper, recycling, generating less and properly disposing of waste, solid and otherwise. Proper disposal of pharmaceuticals, using environmentally benign chemicals, and using more local sustainable produced food. So after giving you a general overview of the project itself, let me use my last 3 minutes to give you an update of where we are now. The project works with 3 outputs. Output 1 is basically all the hospital safety index and green assessments, which created a good database for all the project countries, and they can use that database to attract additional funding. There was a lot of training, so over 1,000 people already has been trained by using the smart toolkit and everything that is part of that toolkit, which includes also maintenance courses and contingency plans. Output 2, which is the most important output, which is actually the retrofitting and the design of the facilities. So the aim we have is by the end of this year, we finished 50 facilities. By the end of the project, the aim is to finish 55 facilities. And we will also hand over 6 full designs. So there will fully smart designs to the Ministry of Health. And those will be providing the Ministry of Health the opportunity to also attract other funding by other donors. Third output is PR. I think it's pretty successful, and thank you for the opportunity to present this project in this symposium as well, which is actually part of this output. So there's many materials. We're on social media, Facebook, Twitter, and Instagram. And I think the project is pretty successful since we see it's applied in other projects and other countries. Some takeaways and challenges, of course. We all see that the COVID-19 pandemic gives us extra challenges in, for example, supply chain, logistics, the increase in construction material, and of course, the travel restrictions. Travel restrictions is a bit of an issue with quality assurance of the design and construction. And I mentioned already the preventative maintenance. Building codes and standards and application of those codes and standards is extremely important. And sometimes our standards are higher than the local standards. The importance of contingency plans, not only plans, but especially standing operating procedures. And very important, the mechanism of check consultants. These people are our experts for second opinion, for a review on structural, mechanical, electronic, plumbing, and also the quantity surveyor check consultant is extremely important. So this is my last slide, the future. We started in 2013 as a concept, and I'm confident to say that by now in the Caribbean at least, we are a smart movement. We see a lot of national partners showing interest. We see a lot of facilities being retrofitted using our standards. And for example, the IDB in other countries is using the concept as well. We have a new courthouse in the BVI to be built, which will be smart. We have the EU doing smart shelters in Belize, BVI, and 2 new shelters, new buildings, so not retrofitting in St. Martin. We continue the guidance for new facilities, and we see a lot of interest from the private sector, and we promote the capacity building. And that's my 8 minutes. Thank you very much for your attention and the possibility to introduce you this project. Thank you.
Thank you very much, Major Buter. That was militarily precise in terms of the time. Really exciting work that you have presented. I'm very fortunate for our colleagues in St. Vincent that the retrofit was done and could withstand the ashfall. I suspect that you will get quite a few questions. Dr. Harvey, over to you.
Good afternoon. I will present on the Smart Health Facilities project in St. Lucia, following from the presentation you have just heard by Clemens Buter. An overview of the presentation is given here, and it's in 3 main parts. The interventions and retrofitting has been completed, and we are now at the stage of monitoring and evaluation of the outcomes. And by looking at our challenges, we have identified some ideas for future work and the research agenda. This slide shows that we have 3 flagship facilities, and these are facilities that are very difficult to evacuate after a major hazard event. The Senior Citizens Home and the Shelter for Abused Children serve the entire island and are the only ones. And the Central Health Facility in the south of the island is our 3rd flagship facility. These were retrofitted to a very high standard of resilience and greenness, the A70 illustrated by Mr. Buter. 12 smaller facilities were upgraded to an increased level of resilience and greenness. And to scale up and to scale out, the project would increase the number of facilities retrofitted and the level of resilience and greenness achieved at each facility. The knowledge, attitude, and practice of both staff and communities has changed and is changing due to the project. Training in conservation of water and energy and contingency planning has developed new habits in the staff members and prepared the staff for emergencies. Data collected in the community around the health center in Vieux Fort is reflecting changes in knowledge, attitude, and practice, and is being assessed by Florida International University at present. This team also is validating a cost effectiveness analysis tool, which pre-retrofit was used to predict the benefits of the project in relation to the cost, and now post-retrofit is being validated by the realized performance. The project is for climate change, adaptation, and mitigation. And adaptation to hurricanes often focuses on wind resistance. We have used locally made timber shutters to protect windows, which are breeze block openings, fixed wooden louvers, and glazed windows. But the locally made timber shutters have not been tested to international standard to prove their wind resistance certification. As a result, Vieux Fort Wellness Center had to use imported aluminum shutters, which had a wind resistance certification internationally. Another adaptation measure to drought is rainwater harvesting, as well as to heavy rainfall, because it controls the runoff. And this has been used for clinical purposes by treating to potable standard, as well as for sanitary and laundry purposes. The systems have been a combination of gravity feed as well as pump supply to the building, and the fixtures, low flow plumbing fixtures, as well as the water treatment system with UV tubes, is not entirely suited to the non-consistent water supply and the level of pressure which is supplied in practice. So this is an area for further investigation and improvement. Our other adaptation to high temperatures is through ventilation, and the use of solar fans and solar shading from the photovoltaic panels at Vieux Fort Wellness Center did not achieve the level of cooling within the ceiling space that the designers intended. In addition to that, we have found in Labrie and other wellness centers that there is a temperature differential between air-conditioned rooms and rooms with natural ventilation assisted by fans. And at the interface, there is a development of mold on the wall surfaces. This is another problem which requires further investigation. Mitigation is meant to provide a maintenance budget because, as Mr. Buter pointed out, staying smart requires a safe and green facility to be well maintained. And savings in utility consumption have been achieved both for water and electricity, but the electricity has proved to be more effective and impactful, particularly where there are photovoltaic systems. The future being to actually sell power to the grid. The project overall has been successful, both in terms of the performance of the green measures as well as the safety measures, which provided backup power and electricity during Hurricane Elsa, July 2021. And therefore, we can confidently say that St. Lucia would welcome you to the Deruso Wellness Center and to all the facilities retrofitted under the Smart Health Facilities Project, which was strengthened to reduce the risks caused by natural hazards and climate change. Thanks for your attention.
Thank you very much, Dr. Harvey. Very, very interesting. And you're gathering empirical data on the effectiveness of some of these interventions. The use of local materials, although they're not certified. I pray you don't have a chance to test the effectiveness of those materials under extreme wind events, but I thought that was very, very innovative. And the interface between your naturally ventilated areas and your air-conditioned areas and the problems you're seeing at that interface. Interesting, and we look forward to hearing from you as to how you resolve those problems. Colleagues, we have, last but not least, Dr. Ravati Falke. Over to you. Ravati, we're not hearing you.
Can you hear me now?
Yes, we can, loud and clear. Please go ahead.
Yeah, so thank you for that introduction, and I hope that this is full screen, yeah?
I'm not seeing it full screen. You're not in presentation mode yet.
Yeah.
There you go. Well, no.
Yep, probably here, right?
Well, you can click on that and see what happens.
Yeah, probably this works. But anyways, I think
no, from now your screen has gone blank. Sorry. There you go. Let's work with that.
I think I will stick to this because otherwise we run out of time. Yeah. So yeah, so thank you very much for having me here, and I will be talking a little bit about how do we work towards developing and setting the research agenda for climate resilient and sustainable health systems. And most of the speakers in this session have highlighted the importance of balancing the sustainability aspects of provision of healthcare, but also having systems which basically can provide the services that they are designed to provide for, but keeping the sustainability angle in mind. And so some of the tensions that we see across health systems, whether in high-income countries, low-income countries, and also in the Caribbean, is how do you have the ambition of providing universal health coverage, which necessarily requires scaling up of function and service, especially service delivery, but at the same time keeping the carbon emissions in check. So if you look at the global healthcare system, healthcare's carbon footprint, it's equivalent to 4.4% of the global net emissions, and this is higher than the aviation sector as well. If you look at infrastructurally, and fantastic examples have been presented today in this session, but if you look at the picture, there is still many healthcare facilities who do struggle with basic wash facilities, and also kind of, the management of waste products that they develop. And then the issue of exposure infrastructurally to extreme weather, especially overheating. We saw examples of the storm activities as well. So it's really a tension between scaling up service delivery, but at the same time maintaining the infrastructural and service integrity within health systems globally. So when we are really talking about strengthening resilience of health systems, there's a triple transition ongoing. One is really, we started off with a very linear model of understanding health systems, and then we slowly moved into the systems thinking approaches. And that also brought out around 2014, the operational framework of the WHO for strengthening climate resilience within health systems. And one transition that we have seen there is we are moving from health systems more focusing on the healthcare facilities, exactly the examples that we also saw in the session earlier today. Alongside the systems thinking approaches that are picking up speed within understanding of health systems, we are also challenging how do we understand resilience. Because when we talk about baselines, when we talk about strengthening resilience, we are essentially talking about the absorption capacity of these systems, and then their ability to return as quickly as possible to baseline. But what baseline? And in the absence of robust assessments which tell us what the state of play is in all of the building blocks of the health system, we do struggle of calibrating these baselines for improving climate resilience within them. And of course, the metrics issue always stays. Health systems are not oblivious to the challenge of attribution. So that is one of the biggest challenges when we are understanding the health impacts of climate change globally. So of course, this also applies to single extreme weather events and how do they interrupt service delivery and what levels of shock the systems can take and for how long. Because this is also about sustained individual events and how does that then affect the system's ability to spring back to higher than baseline functions. So when we look at the research availability across the world, obviously there are disparities, and the disparities not just of geographic regions, but also of topics. So certain topics have, guided by funding to a large extent, have been better investigated. Methods are quite advanced compared to some of the other kind of near neglected topics that we see. And of course, you will probably have to hone in into a specific region to understand where the actual gaps are. But some of them clearly emerge when we try to understand where is our current understanding of both the health impacts of climate change, but also the health systems impacts of climate change. So yes, literature is on the rise. However, where does this literature sit? If we look at two very good exercises that have been completed in 2021 to understand where we are with adaptation research. So one paper with Shilbeek et al. From London School found 99 studies from low and middle income countries, but only 2 of them had ex-ante formal evaluations of climate change adaptation response. So it's not that the evaluations of these projects is not happening, but it's not coming into the open domain. It usually sits in reports or is sitting in individual organizations' databases. So it's not becoming accessible for people to have a collective mass of evidence that can then inform action in other countries. So having that balance and bringing out this evidence in the open is a gap that we need to address. And of course, does this research, the question that we need to ask as practitioners and researchers and policymakers is, does this really support capacity strengthening where it is most needed, whether it is methods, tools, or also the availability of data? And that brings us back to the core approach of strengthening healthcare systems and how are we understanding how these systems are evolving alongside the climate challenges that are also evolving with time. So essentially, these are dynamic processes which are happening quite simultaneously, and we haven't yet uncoded many of the health systems in the world to be able to ask that question then, that how do we strengthen the climate resilience? So given the interdependencies between the different components of health systems, it's quite critical that we do look at the big picture and we do look at the whole system. And that, of course, is incredibly difficult from a methods approach, from the data availability approach, but also from the interest approach of the funding agencies that are supporting this kind of activities in the world. And last but not the least, it's also about what proportion of climate change and health research, although it has been on the rise in the last decade or the last few years, how much of it is focusing really on health systems. And unpublished data from a WHO report, which will be soon coming out, it does say that, you know, out of the 2,000 evidence reports that they reviewed, the impacts of climate change on the healthcare system was covered in less than 4%. Yeah, so what do we need to, where should the ambition be for bringing our understanding to a level where we can actually make the changes in the health system from a climate perspective? So the first thing obviously is to move from impacts to responses, and examples that have been discussed in today's sessions are fantastic proofs of yes, the field is moving in the right direction. However, the challenge of operationalizing resilience in health systems remains. And raising the ambition for our understanding in all regions and also at the different level within the health system. So it's not just about understanding them at the national level, because majority of the adaptation will happen at the local level. So how are we matching up those ambitions of raising research, action-oriented implementation research, which can provide the evidence to policymakers and practitioners like ourselves in providing that. Mitigating barriers, of course, and they are not necessarily limited to resources. Definitely have research which is driven by policy and health protection needs of the people who are actually delivering the services and providing the care. And of course, none of this can be done without sustained and substantial financial commitments over longer periods of time. And of course, the argument of mitigation versus adaptation. There is larger gap in adaptation research at the moment for adaptation within health systems. But also the mitigation challenges remain, and the co-benefits that brings to health in general. And of course, it's not who and how that matters. Of course, it's about how we guide those knowledge ecosystems within the countries, and of course, academic institutions, national public health institutions, practitioners, civil society organizations play a very important role in action-oriented research for strengthening health systems resilience from a climate perspective. I will end with this last slide, which obviously calls for raising the ambition and the urgency with which we need to understand how climate resilience within health systems needs to be achieved. I would like to highlight the Health Systems Global has launched a new climate resilient and sustainable health systems thematic working group, and we are looking to establish a Caribbean chapter. So I would, this is a call for please reach out to us if you would like to set up the chapter or become a member of this movement of policymakers, researchers, and practitioners who will over the next 4 years try to investigate some of these questions in different regions of the world. Thank you very much.
Thank you very much, Dr. Falke. Very, very, very interesting research. Thank you for reminding us, of course, that the healthcare systems actually contribute 4.4% of global emissions, more than twice that of the airline industry. I believe if you added maritime and aviation together, then you would get close to what healthcare systems are actually producing. And then your comments about how do we calibrate the baseline? How do we know what baseline we're getting back to? I mean, that seems to be a perennial problem for us, is having those baseline data. But thank you very much. Colleagues, you see that all our panelists have rejoined us, and we have some time that we can spend on questions and answers. Colleagues, you may see that some questions have already been posted in the chat. Clemens, there are a couple addressed to you. Great to hear the progress with the PAHO Smart Hospital Program, a best buy for the health sector. But then a question about approximately how many hospitals and health centers are there in the Caribbean? How many have been made smart, and how do we accelerate the program? And then the second question for you, Major Buter, is PAHO providing some funding to governments for retrofitting of the hospitals? Is that funding and work being done balanced by PAHO, or is it left solely up to the governments? And I have a couple of questions for you too as well. So please go ahead with those two. Over to you.
Yeah, thank you, Dr. Seeley. Yeah, there's many healthcare facilities. I don't know on top of my head the total, but I know that when we started the assessment, I think we calculated a total of 650 healthcare facilities, at least in the region. The team, and we have teams in every participating country, they did a total of 450 assessments. And then I talk about the Hospital Safety Index and green. And only out of those, with the funding we currently have, we were able to do, or we are able to finish like 55. So there's still a long way to go. But I think the interesting thing from it is that the countries do have the surveys, the assessments. So they actually have a database now when they can talk to different funding, different donors, for example, the World Bank or IDB, or we see the EU as well. And that they have this database at hand and they can show actually this is what we need to do and this is how much funding we need to retrofit these facilities. And I think using that database, which actually happens at the moment, because we do see adaptation by the EU, by the World Bank, the OECS, that the database is being used. And of course, I'm very grateful we use every opportunity like this symposium to spread the word and to accelerate. The other question, let me quickly scroll.
That was the one on PAHO funding.
Yeah.
And
the system we have is basically that the donor, in our case FCDO, they provide the funding to PAHO, and then in very close collaboration with the end user, the owner of the facility, which is the country, the Ministry of Health, the funds are spent. But basically the contracts are between PAHO and the design firms or the inspection firms and the contractors. But everything we do, every decision being made, including of course which facility to retrofit, is done in very close collaboration with the Ministry of Health of the countries.
Thank you very much. Quick question for you from my side, since I have the mic. You said 58% reduction in electricity costs, at least for one of the facilities. Could you convert that into what the payback period would have been then for that investment? Do you have any idea? Because it sounds really, really great. I think I'm more than half in my electricity bill.
Yeah, no, it's actually, we are, as we speak, we're calculating, to be honest, and Judith knows as well. So I'm hunting down the countries to provide the utility bills to really calculate, okay, what is the saving, what we achieve. But I do know that some of the facilities, they now have so many solar panels on the roof that they are actually able to run independently from the grid. And then we can provide them with batteries as well. So even when there's overcapacity, they can store that electricity in batteries as well. So if there's no power available from the grid or solar panel, we always have the batteries as backup. So we're doing the calculations, but I do know that some facilities, they don't use any power anymore from the grid. So it's a huge step forward.
Okay. Well, hopefully we'll hear those numbers when you actually get the utility bills, and we can figure out what actual savings are being accrued. Dr. Jury, the next question was on, and I think it was partly answered by Major Buter, was give an estimate of the percentage of the healthcare facilities in your region have taken measures to be safe and more green, carbon footprint perspective. Do you want to take a shot at that one, Jonathan?
Yeah, what I can say about that is really PAHO is supporting right now with the COP26 a number of commitments from the countries, and one of those is that countries commit to reductions in emissions from their healthcare facilities. And really the first step in that is doing an estimate of contributions from healthcare facilities and then putting together a plan of action in order to deal with it. So those are the first two steps that have come out of the COP26 that we're supporting in the Caribbean, and a number of countries are going to get on board with that. Thanks.
Thank you, Dr. Jury. I've been told that we can run a wee bit over time, just a wee bit. So since we have the civil engineer here, Dr. Harvey, the next one is at you, and the use of the cross Q. Do you want to address that? Building codes, have we included cross Q, the regional standards organization, to explore the possibility of adoption of these? Seems as if we might consider an aggregated standard that addresses all issues addressed under this project. Well, what's your response to that?
I can say that the OECS Secretariat here in St. Lucia was leading a project which was modifying and updating the regional building codes. And I am not certain of the exact status or the involvement of the different organizations such as CrossQ, but in principle, the community has a mandate and a goal of an updated regional building code. And in fact, the wind hazard, for example, has a climate change component already superimposed on the hazard maps. So the forward-looking aspect of it, certainly from the wind perspective, is there, and the climate change aspect as well is there. Yeah.
Okay, thank you, Dr. Harvey. We've got two more questions that we can quickly address, I hope. The one on rainwater harvesting, are we doing it as part of this project? And if we are, how are we managing the stored water and preventing mosquitoes from breeding? Who wants to take that one? Clemens or Judah?
Well, I was going to quickly say that we do try to put on a mesh on the intake and exits for the water tanks. We have implemented low flow fixtures to try and minimize the usage of the rainwater and the UV treatment as well. But really, we haven't gotten the science completely. So this is an area for further research. And that's why I highlighted it as part of my presentation.
Thank you. And then the last one seems a bit of a curveball. I'm not sure who's going to address this one. Are we including health in technological and financial decisions for food security, including on the islands, import of soil microbes, soil regeneration, permaculture? Dr. Drury, Dr. Falke, I don't know who wants to take this one on.
I think Clements does. No, for the project, we do, it's related. I guess we do have a food safety component, but that is really looking at, what are emerging food safety risks linked to climate change in the Caribbean, and then updating, food safety manuals and how do we integrate that climate resilient component, foodborne disease surveillance manuals, and training along the food safety chain, and trying to really integrate climate into that and into the training that we do. So I think that sort of gets at it a bit. I don't know, that's not a direct answer, but the idea is to develop a number of climate resilient food safety plans across Caribbean countries and organize training so they can better detect, food-borne pathogens, and training on how to collect samples and things like that. Over.
Thank you, Dr. Drury. Panelists, I think we may have overstayed our welcome by a few minutes. I really want to thank you, Dr. Drury, Dr. Harvey, Dr. Falke, Major Buter, for your excellent presentations, and thank you for the questions from the participants. Colleagues, thank you, and this session has just ended. Thank you.
Thank you.